for an excellent talk and the panelists for an excellent interaction. Thank the organizers for an excellent arrangements. Thank you, everyone.
To kindly remain on stage, the moderators and the chairpersons for a photograph. Thank you very much. Again, just an announcement that the winners will be announced at the end of the session, and those who are remaining only will get it. In case the winner is not there, it goes to the next person. Just to remind you on that. 2 gifts, right? We are getting a Samsung Galaxy Note and Alexa. I'm also exactly waiting for the winners. Thank you very much. We go to the next session now. It's Binary Bedlam and Emergencies. And they've used the word Baro Palwan. So it's a Telugu and Hindi term combined together. And here for this, I call upon the chairpersons, Dr. K.R. Palniswamy, the Senior Consultant Gastroenterologist, Apollo Hospitals, Chennai, and Dr. P.K. Reddy, Senior Consultant Laparoscopic Surgeon, Apollo Hospitals, Chennai, to please grace the occasion and to occupy the chairperson's place. And we do have a very important person who will be doing the moderation for us today. Dr. Rajkumar Wadhwa is the Chief Gastroenterologist and Head of Institute of Gastroenterology, Apollo BGS Hospitals, Mysore. So we call you onto the stage, please. We have 5 people who will be gracing the panelist section over here, and that will be Dr. Basumani P, Consultant Gastroenterologist, Sri Ramachandra Institute of Higher Education and Research, Srihar, Dr. S. Shankar, Professor and HOD, Surgical Gastroenterology, Sri Ramachandra Institute of Higher Education and Research, Dr. Sendil Kumar Rajagopal, Senior Consultant, Intensivist, Department of Critical Care, Apollo Hospitals, Chennai, Dr. Ganesh Ramasubbu, Consultant Emergency Medicine, Apollo Hospitals, Greens Road, and Dr. Satish Ramamurthy, the Consultant Interventional Radiologist, Apollo Hospital, Greens Road. Thank you very much.
Good morning, everybody. It's a great pleasure to be here, and I'm thankful to the organizers for inviting me to chair this session along with Professor Palniswamy. Biliary emergencies is a very common problem. It occurs as it is without any intervention or with interventions like surgery or endoscopies. And these are the ones which we need to tackle them in both the minimally invasive way or endoscopic way or surgical procedures. And we have an excellent speaker, Dr. Rajkumar Wadhwa, about who is going to moderate this session, and Professor Palniswamy will be introducing the speaker.
Good morning. I'm very happy to introduce a good friend of mine, Dr. Rajkumar Wadhwa. So Dr. Rajkumar Wadhwa is the head of gastroenterology at Apollo Hospital, Mysore. And basically, Dr. Rajkumar is from Nagpur, and then of course he did his gastroenterology from Bombay. And he's a good academician and researcher. He has published several articles. He was invited faculties in many international meetings and many workshops, like US workshops all over the world. And I have tried to watch him growing. In fact, he used to work in Madurai and subsequently in Chennai. And he has held several workshops in Mysore when he was working in Vikram Hospital. I watched his workshops and the CME programs. Really, Dr. Rajkumar, I miss your programs. I don't know. You've been very active in conducting the workshops and the international meetings. I hope I'm looking forward to the future meetings. So I request you to sort of start your the moderation.
While the thing is going on. Um, Thank you, organizers, for allowing me to stand here and moderate this session. And giving me a privilege where my teachers are sitting on my right. I have grown up looking up to them, following their principles of practice medicine. And I hope I have done something which probably will make them proud sometime someday. And on the left-hand side, I have a very, very eminent specialist in the field of gastroenterology, while I will be probing them with the questions, and we hope that they will give you a lot of answers today. Some things I would like to tell. I will be asking them some questions based on images. However, please understand that we don't do diagnosis based on a single image in a clinical setting. So if in case any difficulties, I will be assisting them because I'm not giving them the true clinical findings in that situation. For example, CT scans, we will sit and go through it again and again, and not based on one ultrasound or one CT scan images. You can see.
Since Dr. Rajkumar is organizing his topic now, I would like to say I thoroughly enjoyed the breathtaking session by Dr. Radhakrishna. He is really very interesting actually. If you put the same questions to me, 100% I will fail actually, I will not pass. And very nicely he has constituted all the questions. That is followed by excellent exposition by Dr. Anand. Anand has made the entire discussion of the acute pancreatitis very well. The last but not the least, they were all talking about the direct approach for a surgery and all. Yes, as Dr. Jaswant said, I do agree with him very much. But as far as the literature is concerned now, step-up approach is the treatment of choice rather than directly going in. But still, I prefer to do straight away. Thank you.
As we all know, the classic three biliary emergencies are acute cholangitis, acute pancreatitis, and acute cholecystitis. I'm dropping acute pancreatitis because in the previous session we have discussed probably a lot of pancreatitis, so I don't think we'll be repeating those things again. We'll start with the case scenarios. I have a lot of case scenarios of a different etiology. However, the basic first two cases will discuss about the broader aspects and specific etiology subsequently later on if we have a time to do that. A 31-year-old male presented to emergency with pain in abdomen of 1 week duration, epigastric, radiating to back, passing dark colored urine since 1 week, fever with chills and rigors since 2 days. He has a history of alcohol consumption for last 6 years, and on examination, he is a tachycardic, he is febrile and hypotensive. He has icterus. On examination, he has tender hepatomegaly, but he does not have organs palpable. What do you think we should do in this situation when this patient presents to us in emergency? And what could be the possible differential diagnosis also?
Essentially, the patient is having epigastric pain, radiating back, history of alcohol intake, nothing that I have to go is reservations and pancreatitis or not. Moreover, the patient is having acute cystitis, tachycardia, hypertension, and fever. Again, if you put it all together, on examination, you got a jaundice too. So I would like to do is there any pictures of cholestasis or any enzyme raised in the liver because of pancreatitis complicating the bile duct obstruction? So it's a mixed picture. But anyway, from the ER point of view, what we do is we treat them as a sepsis patient. We follow the sepsis 6 bundle, like maintaining adequate oxygenation, and then fluid resuscitation with at least 30 ml per kg, and then we'll take blood cultures and start with the antibiotics. To find out the cause, the pancreatitis is because of the alcohol or it's complicating the biliary obstruction, then we do an ultrasound to look for any collections there.
Yeah, I think a general presentation like this would put me to indication that this is one of the pancreaticobiliary disorders. It could be pancreatitis. He has a history of alcohol consumption, which can give an idea about it. It could be acute cholecystitis and biliary colic. In addition to that, tender hepatomegaly again indicates that he could have an associated liver disease also. So it's a mixture, a very common day-to-day scenario in these circumstances. The preliminary investigations and the resuscitation happens in emergency. We have discussed the broad principles of resuscitation yesterday during the surgical thing. We stand with the similar principles of resuscitation today also. The basic principles in this will be resuscitation, medications, what investigations and what interventions at what time. So we will first go to, after the resuscitation investigation, these were the investigations present. Hematologically, his hemoglobin was 15.7 grams per cent. He had polymorphonuclear leukocytosis. His total bilirubin was 6.5, with majority of it showing as a cholestatic pattern of obstruction. His ultrasound features were something like this. Can Dr. Satish help us as to what he looks at in this?
This looks like acute cholecystitis. The wall of the GB is thickened. I cannot see any calculi per se in this, but this is just one slice of the image, so we'd like to look at that. The CBD is not significantly dilated. There's no measurement, but looking at it, probably about 4 millimeters, 5 millimeters. So it just looks like an acute cholecystitis picture.
Okay. Would you like to have any other investigations before we go ahead and do something further, or this should be good enough for us to take a definitive treatment in these circumstances?
Only thing you will not know from here is whether there is gangrene, and something like a Merit is possible where the CBD is not dilated, but you've got a stone that is perforating from the neck of the gallbladder. So if the patient is definitely sick, like what you just mentioned, an MRCP may be better.
Okay. Actually, we were not very sure because this was a mix of the thing. Our ultrasonologist said that there is a cystic lesion which was not clearly seen in this image, so sir will not be able to give me an idea. CBD was mildly dilated but not grossly dilated. We went ahead and decided to do a CT, and based on CT findings, subsequently both an MRI. Sir, can you help us now as to what findings you see on these two imaging features?
Now, on the CT, it looks more like intrahepatic rather than a CBD, and there's some septations there. So highlighted as something that we need to consider. But the MRCP, there seems to be communication with the biliary tree. So it could be just a biliary abscess, possibly, because the gallbladder there is not dilated. It's just an intrahepatic collection. Our medical gastroenterology colleagues would like to comment on these findings on CT and MRI.
As Satish said, we can see hepatic lesion, but also there is a filling defect in the common hepatic duct with some upstream dilatations. So something has ruptured into the biliary system.
Okay. I think we were a little surprised after the ultrasound that this was the picture on CT scan. It showed a cystic cavity with possible daughter cyst inside, and MRCP told us that there is a possible biliary communication with CBD grossly dilated in this situation. So the diagnosis was acute cholangitis, patient in sepsis, secondary to hiatus in the right lobe of the liver with possible biliary communication. Now what should be done? This was the first differential diagnosis. Dr. Shankar?
So the picture is very classical of hiatus cyst in the liver. And because of the clinical presentation, it looks like it has ruptured into the biliary tree. So, and the patient is in cholangitis. So the first option is to tackle the cholangitis. I would ask for a ERCP and clearance of the bile duct of all the daughter cyst debris. And then once the patient is stable, I will plan for surgery.
Okay, that's fair enough. As far as acute cholangitis is concerned, before we think of any intervention, we would like to start on antibiotics. Dr. Basubani, what antibiotics, or Dr. Senthilkumar, what antibiotics would you feel in this situation we should start?
See, the common bugs in acute cholangitis is the Enterobacteriaceae. Almost 1/3 of the infection is because of E. coli infections. And second is Klebsiella. And sometimes we see Enterobacter, and gram-positive Enterococcus is also possible in around 15% of the patients. So these are the common bugs that should come in our mind before we start the antibiotic. The second thing is the bioavailability of the antibiotic. So these two things we need to see: what bug we want to cover and what drug will have a good bioavailability in the biliary tract is also very important. So the bioavailability is best with the piperazoline, tazobactam, carbapenems, tigecycline. These are the drugs which have a very good bioavailability in the biliary system. So in this patient who is very sick because he has a shock, typically the numbers showed a polymorphs of around 90%. That means the MLR is huge, and BPS around 90-60 with a heart rate of 126. So I will go with the drug which has a good bioavailability and has a very good bactericidal effect, like a carbapenem in this patient. So again, within the carbapenem, imipenem has a higher bioavailability than meropenem. So that will be the drug of choice to start with in this patient. 1 gram TDS or a QAD dose of imipenem will be a very good dose to start with.
Okay, I think that's fair enough. These are the antibiotics which have been prescribed for an empiric starting, that is piperacillin, tazobactam, or ticarcillin, clavulanic, and if monotherapy, a carbapenem, imipenem, celestine combination, or meropenem should be the starting point, as sir has very lucidly told us. The second point which Dr. Shankar raised was biliary drainage. Now, patient is sick in emergency. You have, after the initial resuscitation, you have diagnosed that patient is having cholangitis. Do you straight away take him for biliary drainage? Do you wait for some time? What do you feel, Dr. Basumani, Dr. Shankar? What are the criteria when you will say that this is the time I would like to do an emergency biliary drainage, or this is the time when I would like to give fluid, antibiotics, wait for a certain period of time, and then electively take him up for the biliary?
So one thing I would like to share with especially junior colleagues is, unlike other sepsis, ascending pyelonephritis and ascending cholangitis, you need to imagine a battalion of bacteria going up a narrow tube, and once they reach the organ like kidney or liver, the surface area of this bacteria to multiply, and to become septic shock is only few hours. So every minute and every hour is important. So whenever you suspect a pyelonephritis and cholangitis, equally like meningitis and pneumonia, you should not delay antibiotic, and you should choose best guess antibiotic. The second is drainage, both for obstructed kidney and obstructed bile system. When the patient quickly responds to resuscitation, it may be prudent to delay until the safe hours of next day morning. But if the patient is not responding, an early ERCP and just opening the sphincter, clearing the debris, and popping a 10 French stent is the only way to improve the prognosis of this patient, because from high lactic acidosis and septic shock, reasonable quick recovery and emergency. This is one of the indication. Active cholangitis, worsening jaundice, and failure to improve it anyway. Maybe I will give a couple of hours and then plan for emergency. Yes.
Dr. Shankar, your experience?
Yes, sir. Obviously, we have to resuscitate the patient with antibiotics, try to stabilize the patient. And I don't think we can set a set period like 12 hours or 24 hours. So once the patient is stable, we have to take up for the drainage. We have to basically balance that you control the infection with antibiotics. At the same time, we should not be oblivious of the fact that there is an obstruction there. So you got any amount of antibiotics will not take care of the obstruction. So we'll have to strike a balance, and maybe within 24 hours we can plan for that. And especially we are worried about the coagulopathy. So that has to be corrected. And if the patient is a diabetic and ketoacidosis, that has to be corrected. So we have to stabilize the patient and then plan for a thing.
So in majority of the times, that is in more than 80% of the cases, we initially stabilize the patient, both with fluids and the comorbid conditions in these situations needs to be stabilized before we embark on ERCP. Now we have two modalities commonly used for the drainage. Of course, the third one is in increasing use of endoscopic ultrasound, but conventionally we use either ERCP or percutaneous biliary drainage. What are the indications of these two specific situations? What would you choose in which particular situation?
Obviously, when we anticipate failed ERCP due to previous history of surgery, difficult access, and if the imaging shows very large, not in this example, okay, a large stone where we expect a difficulty of CVD clearance. And if the initial attempt at ERCP elsewhere has been failed, then better, and in unstable patient, because of lack of need for anesthesia, we can choose PTPD as a temporizing measure, and then go for definitely ERCP later. In all other situations, I will choose ERCP, especially if the patient is stable and fit for sedation.
Okay. So the answer to the first question, the situations in which we will go ahead and do an urgent biliary drainage, that is the persistent abdominal pain, severe abdominal pain, whether after giving the resuscitation, hypotension, persistent, high-grade fever, and mental confusion or erratic mental behavior. These are the situations in which we would not like to wait for a very long period of time, but take them up for the biliary drainage. As far as the choice is concerned, once the patient is stable, there is a lower CVD obstruction, preferably it should be ERCP. In the situations when the patient is unstable and you are not able to stabilize and you have a good radiologist, then PTPD should be the method in these circumstances.
A very nice discussion, but once the patient is stabilized for a few hours, now the endoscopists are so good, they hardly take a matter of few minutes to cannulate the bile duct. So that's the best way of biliary decompression to start with.
I agree with you. Majority of the times it is, I'm highlighting here that we do have an alternate way in situations. If a patient is BP is not stabilizing, patient is hovering in 60, 70, 80 systolic blood pressure, then probably we should consider PTBD if we have a good radiologist in this situation. And anatomy also allows it. In these circumstances, probably not, because biliary duct dilatations are not there. This was the patient's ERCP. What is this, what you are seeing here on the papilla?
You see this laminated membrane.
It will get clear in a couple of minutes. Basically, a white nipple papilla, as it is called, is seen in a situation of biliary hydatidosis, where the membrane of the papilla projects through the papillary thing, as in this case, this was actually the membrane. The entire membranes were cleared up in these situations. and a stent was placed. This patient was continued on antibiotics, and fortunately for this patient, over the next few weeks, this patient completely drained his intrahepatic cyst also through the bile duct, and we did not follow it up for the surgery. Is this possible?
I don't think that's possible. I mean, once you clear the bile duct, this is a fairly large enough cyst. So you can't expect your albendazole to completely cure this hieratic. So I strongly feel that this patient needs a surgical intervention.
I would just like to show you the amount of actually the cyst, pericystal thing which came out of this. This was virtually the cyst draining into the duodenum. Okay, can you see those things? This is a little older case and I do not have the follow-up CT, but he completely collapsed. In fact, these are cases that are described in literature. When you have a large communication between the cyst and the major bile duct, then it is known to empty into the bile duct completely. May not require a surgery in this situation. However, do we require a chemotherapy at least? Dr. Basu?
Yes.
What kind of chemotherapy? How long you will give?
I don't know personally. I will ask my microbiology colleague. No, what's the duration?
Sir,
Recommendations: albendazole 10 milligram per kg body weight in 2 divided doses. It is given for 15 days. After that, you have to give a drug holiday of 15 days, and then you restart after 15 days. You have to do a LFT and a CBC. Like this, you can continue 3 or 4 cycles. There are no set recommendations.
okay.
But albendazole can be used for a very small lesion, or it is predominantly used preoperatively to take care of the intraoperative spillage that is likely to happen. So albendazole per se as a standalone treatment for a hieratic cyst can be recommended only for a small lesion, and not for this lesion, especially this lesion is in segment 6 or 7, which is far away from the central biliary radicals. So it's unlikely that it will have a very large communication. So this case will need a surgery.
Can a radiologist look at the MRI back and comment on the size of communication? Hello?
Can you give a mic there?
When everything is dry, there is biliary communication. And bile itself is a coagulation agent, actually. So we need drugs or not.
I can't hear.
Once hieratic communicates with the biliary system, it itself acts as a coagulation agent, actually.
Okay.
So we need any drug or not.
Okay,
Once bile communication won't survive, actually. Bile.
I'm sorry, can you please come and speak in front? Your voice is very low.
Once there is biliary communication, they don't survive. No, not patient. Hieratic won't survive. Coagulation won't survive.
Okay. I have no reference to that. I am not aware of that. It will not survive.
Sir, I mean, sir, are you trying to tell if there is a biliary communication, you don't need to treat?
No. When everything is emptied, whether drug is effective or this is effective, that's the thing.
Okay.
You don't go for surgery, drug is not the treatment of choice.
I have no direct reference available in literature to say that the hieratic cyst, once it ruptures into biliary system, that it does not survive. Yes, but there are clear-cut recommendations that it should be followed up with chemotherapy. These are the few drugs which can be used. These are albendazole, mebendazole, and praziquantel, which can be given in these situations. They are given in cyclical fashion, as sir has already said. Albendazole at 10 to 15 milligram. Usually it is given in the cycles of 4 weeks, 2 weeks holidays, 4 weeks, 2 weeks holidays. And we have to monitor the liver function test as has been suggested. But the alternates are mebendazole and praziquantel, which can be given in these situations. The important thing is never, a follow-up should never have a pair as a treatment. If the cyst is persisting, this cyst has to undergo surgery. Never use a pair, because we are going to be injecting in view of presence of communication, injecting this alcohol directly into the biliary system. We will go on to the second case. This is a 70-year-old female present late in the night to an emergency ward with severe right upper abdominal pain with fever, nausea and vomiting for the past 4 days, constipation for the last 3 days. She is a diabetic, hypertensive and has a history of ischemic heart disease for the last 20 years. On examination, patient appeared drowsy, ill-looking, tachycardia is present. There is an increase of blood pressure with mild fever. There is a tachypnea with low oxygen sets when presented in emergency. There is no icterus. There is a tenderness of right upper abdomen with Murphy's sign positive. Other system examination was normal. She was on medications. There was a combination of multiple OHAs, atenolol and aspirin clopidogrel combination. Lab investigation showed high total count, high polymorphonuclear count, high blood urea and serum creatinine. Hemoglobin, platelets, amylase, lipase, liver function test and coagulation profile were normal. ABG revealed metabolic acidosis and echo was asked for, and which showed regional wall motion abnormalities and ejection fraction of 30%. In the emergency, basic parameters, after taking the basic parameters, she was started on antibiotics, sugar control measures, rehydration, and other supportive medications, including the respiratory support, which was given to her, that is starting the oxygen supplementation. Dr. Shankar, your assessment, please.
For me, it looks like acute cholecystitis because sudden onset of pain right upper quadrant and LFT is normal, amylase like is not elevated. So most likely it could be acute cholecystitis. But this patient is a 70-year-old lady with comorbidities on aspirin clopidogrel combination. Ejection fraction is 30%. So she will not be a candidate for immediate surgery. So in such case, I would prefer to do a percutaneous cholecystostomy.
Okay.
Percutaneous transhepatic cholecystostomy.
Okay. Dr. Satish, this was the ultrasound done. I have highlighted certain things with the help of my radiology, but I would like you to give an idea of when and what parameters tell you that these are the classic acute cholecystitis.
I mean, you highlighted the three important ones. There is a big stone that's occluding. There is wall thickening. I mean, the recommendation is anything more than 4 millimeters, you have to take it seriously, wall thickening, and mild amount of pericholecystic fluid also. And clinically, there is Murphy's sign and she is sick. So everything fits into this being an acute calculus cholecystitis.
Okay, so we are here agreeing on a very simple basic parameter that an elderly lady presented with right upper abdominal pain, positive Murphy's sign, and has features of acute cholecystitis on ultrasound. But the caveat here is she is having multiple comorbid illnesses and probably is a high risk of surgery at this point of time. This patient was in the night, no emergency procedure was done, but she was started on these measures. On second morning, her condition worsened. She became oliguric, pulse increased to 110 per minute, BP further increased, and serum creatinine increased to 4.1. Her respiratory distress worsened and she was intubated. She was started initially on amlodipine and intravenous labetalol to control her blood pressure, and subsequently on intravenous glycerin trinitrate infusion. She also started developing purpuric rashes and her platelet count deteriorated. The high point is patient coming in the middle of the night with acute cholecystitis. Should we do the emergency percutaneous cholecystostomy in the middle of the night, or should we wait till next day morning? Dr. Satish, please.
Most certainly wait. I think give her proposal of antibiotics, which she's not had before.
Okay.
Optimize better.
But in this patient, we
But
found
this is-
that in a very short period of time, she has deteriorated.
That's hindsight because normally patients don't behave this way. Or normally give them antibiotics and kind of make sure that you optimize them better.
So Dr. Satish agrees that probably we would not have been benefited if we would have intervened right in the middle of the night in these situations. How do you classify severity of acute cholecystitis, Dr. Basamani and Dr. Shankar? Clinically to judge as to which is a mild acute cholecystitis, which is moderately severe or severe acute cholecystitis, and what parameters you take in clinical judgment?
Actually, there is a Tokyo guidelines, which I don't remember.
I will help you, sir. Don't worry about that.
So, but I think it's a clinical decision. Sir. It's a clinical decision. You don't need a great scoring system to say which patient needs. You have to go in early and do it. So I think finally it's a clinical judgment. And but if the patient is stable, no comorbidities, and if it's a calculus cholecystitis, I want to strongly emphasize the point that this patient needs early cholecystectomy. Early cholecystectomy is not equivalent to emergency cholecystectomy. It should not be done in the middle of the night because it can end up in a problem. Because doing a laparoscopic cholecystectomy on a acute cholecystitis is a different ball game. So the answer, early cholecystectomy is done on the next day morning. So if there are no comorbidities, there is no point in giving a course of antibiotics and doing a surgery after 2 to 3 days. If the patient comes early, go for early surgery. Early surgery is the next day morning as an elective procedure.
As Dr. Shankar pointed out, there are Tokyo guidelines for classification of cholecystitis into mild, moderate, and severe. All of us can find it onto the textbook, but most important thing is when you have a comorbid illnesses and there are severe signs of hypotension, neurologic deterioration, liver failure, and prolongation of PT and INR, these are the conditions where an early surgery probably will be deferred, which was the case in this situation. But in grade 1 and grade 2, you will take this patient up for laparoscopic cholecystectomy after the initial resuscitation. We will not rush to do anything in the middle of the night in these situations, but probably will wait for 12 to 24 hours till the patient stabilizes and then take him up for the early laparoscopic cholecystectomy. We have already decided that we will be intervening in this situation, and this was the intervention done. This is the catheter transhepatic percutaneous gallbladder drainage, as Saraj suggested. You can see the catheter going through the liver into the gallbladder. This patient improved with what you call it as percutaneous cholecystostomy. What are the other indications you feel you have, sir? And do we have the alternate drainage options? If we don't have a radiologist who is willing to put us a thing, do we consider any alternate drainage options in these situations? Dr. Basamani?
We can do it endoscopic ultrasound. So US guided drainage will temporize the patient, and also if we can use lamps, we can also use the track to remove the obstructive stones. So US is another option, but that needs sedation. But if the patient is already intubated, then that gives an opportunity. It's the first choice is always intervention radiologist.
Okay, any other options?
The old option of doing under local anesthesia, you can make a small incision and do a open cholecystostomy.
Okay. These are the classical Tokyo guideline indications for percutaneous cholecystostomy. That is a severe acute cholecystitis according to 2018 Tokyo guidelines. Acute cholecystitis is a classification of more than 3 or comorbidity index of more than 6, and certain situations where you may require a cholecystostomy, although not commonly performed. That includes a malignant biliary tract lesion, bridging, stricture dilatation, fistula output diversion, and decompression in cholangitis. Of course, these are not practiced, as sir has already said that our medical colleagues are now so good that they prefer to do the ERCP. There are 3 defined ways of draining a gallbladder. That is a percutaneous gallbladder drainage, as we discussed, ERCP, placement of stent in the gallbladder through papilla, and gallbladder drainage through endoscopic ultrasound. They have their own preferences. Each of us have their own preferences based on the technical availability of the expertise in a particular situation. and each of these have advantages or disadvantages. While the endoscopic ultrasound and PTBD have a high success rate and clinical success rate, that is the technical success rate of placement and the clinical success rate. However, PTBD has the highest complication rate among the three of them, while the ERCP is the lowest success rate, and that is why none of our colleagues were even actually thinking about ERCP as the alternative modality. So ERCP or endoscopic transpapillary, we don't normally commonly think about using a gallbladder drainage in an acute cholecystitis. However, endoscopic ultrasound has come as a viable alternative. When the techniques are available now, it should be preferred over percutaneous situation because we are reducing the complications as far as the overall complication rates are concerned. This is from a recent meta-analysis published in February 2022. So another third short case, 34-year-old Tibetan monk had undergone ERCP, CBD stone extraction followed by uneventful cholecystectomy. While basic cholangitis and cholecystitis principles of management remaining the same, we will focus in the next 2-3 cases about the etiologic diagnosis and the specific management of etiology. He had presented with recurrent upper abdominal pain for last 7 months, treated himself as gastritis, and kept on taking PPIs and painkillers during this period of time. He developed fever with chills and passing dark-colored urine for 7 days. He had altered sensorium just before. Actually, altered sensorium prompted his friends and relatives to bring him to the hospital. He was detected to be diabetic and on oral medication for the last 2 years. He was febrile, had tachycardia, had hypotension, again, all the features of acute cholecystitis. However, apart from diabetes, he did not have any significant comorbid illnesses. What investigations in this situation? He has already undergone a ERCP as well as cholecystectomy.
So while thinking about the investigation, think of the possibilities. There could be a remnant gallbladder, cystic stone, or there could be possibility of choledocholithiasis, a slip stone or another stone formation, or post-cholecystitis stricture, causing cholangitis, things like that. So I will definitely use investigations, initially ultrasound. And if that gives the answer, gives the etiology, I will stop there. Otherwise, I will proceed with CT, MRCP, and endoscopic ultrasound until I find the etiology.
Okay, Dr. Shankar. Features of acute cholangitis in a post-cholecystectomy state.
Actually, this cholecystectomy was done nearly 15 years back in 2008, and it says that it was an uneventful cholecystectomy, and they have cleared the bile duct before the procedure. So now 15 years later, the patient presents with this kind of picture. I definitely rule out choledocholithiasis because the stricture is very unlikely after so many years. And in this case, I don't think simple ultrasound will help me because it's not going to give great information because there is the gallbladder is not there. So I would prefer to go for a MR cholangiogram.
Okay. Consideration of stones in the CBD, the post-cholecystectomy state, probably still the right choice. Sir, what would you consider if there is a stone in this? Is it a de novo stone present before, or it has formed a new one? How do you decide?
This is a classical Madden's. There are two criteria: Madden's criteria and Zakaria criteria for primary CBD stone. This will come under this very well fits in with an entity called primary CBD stones. So because three years is the cutoff for that criteria, and if the stone happens to be a soft brown earthy stone, non-faceted, it fits in with the primary CBD stones.
Okay. So before 3 years, if you find a stone, you are most likely dealing with a missed choledocholithiasis at the initial cholecystectomy, and beyond 3 years, with the characteristics of the stones, you are dealing with a de novo formation of CBD stone in this situation. His investigation showed that he again had a leukocytosis, mixed hyperbilirubinemia with elevated alkaline phosphatase with normal PTINR. Renal parameters were normal, sugars were high. Patient was stabilized with IV fluids, antibiotics, and sugar, while ultrasound we felt that may not be required, but this was the clear picture of ultrasound. Dr. Satish, please.
Does look like there's no doctor. Sometimes you can confuse the portal vein to the CBD. So I presume that is the CBD, yeah, which shows a small stone within it with the posterior acoustic shadowing. So that looks like a CBD stone. But most certainly, I would go on and do an MRCP to confirm.
Okay. This patient who has presented with classical cholangitis, our ultrasonologists were very confident that they have a CBD stone inside. I decided not to do the MRCP or US in this because I have a clear-cut diagnosis. Elevated bilirubin, dilated CBD, presence of stones and features of cholangitis. I will not do any further investigation because ERCP gives me the idea about the status of CBD in these situations, as well as give me an option of treatment, while both these investigations will add to the cost right at this point of time with the clinical backing available to me. And we did this ERCP. This was the ERCP picture. I'm sorry, just click to it. This was a very characteristic ERCP picture. Dr. Satish, would you like to comment on it?
There is a filling defect in the lower end of the CBD, so which is fitting with our ultrasound picture. So I guess it's just a CBD stone.
Okay, it's a simple CBD stone. Okay, my film is not moving, but I think we have the classical picture on this. There's a very, very unique thing which is present on the stone. It is stuck to me when I was doing an ER. Can anybody point out?
So within the CBD, within the stone, there is some.
There's a linear hyperechoic shadow within the stone. While I was doing an ERCP, it kind of, I felt there's something inside. It might have been an origin of the stone in these circumstances. What we did is we actually removed these stone. My film is not moving, in which there is a serial documentation of these things. We picked up the stone when we removed it and brought it out. We took an X-ray of this stone, which again showed this classical central scar. We broke the stone and we found a clip inside. Can Dr. Shankar would like to comment on this?
I mean, it's very interesting, sir. Apart from that, I don't have any experience.
Yes,
Can I comment on that?
Yeah.
It is not difficult to explain about this, because the reason for it is this must be a stone in the cystic duct stump. Along with the clip, it got merged and entered into the bile.
See, the important thing why I said was this patient has undergone a cholecystectomy 15 years back. And now he is presenting with cholangitis with something like this. There are instances, there are about 40 reported cases in literature of what we call it as clip choledocholithiasis. It is believed that if you have an inflammation post-operatively where you have placed the clip and you have a raised intra-abdominal pressure, then the clip can migrate in this manner sequentially into the bile duct, where the stone is formed usually at the junction of the cystic duct and the bile duct, and eventually it migrates into the CBD, giving rise to what we saw on this picture as clip choledocholithiasis. This was a simple case of acute cholangitis, but with a very unique etiology. Hence, I thought it will be useful for us to understand something very unique. Thank you very much for your kind attention. I have a couple of more cases, but I think the time doesn't permit. I would like our chairpersons to comment on it, and I think all of us as a panelist would like to take questions.
I think Rajkumar, wonderful collection of cases, enjoyed the cases, good interaction by the panelists. I would like to thank the panelists also. Coming from Dr. Reddy.
Very interesting cases, and the highlighted six in particular. And as the panelist said also, if the endoscopist is very patient endoscopist, you can remove the undulating membrane slowly Otherwise, surgery is the ideal method of choice. And as far as the cholangitis is concerned, which you were talking, the ultrasound which you showed, that is a classical mucocele or empyema of the gallbladder. When the patient is on antiplatelet drugs, even the interventional radiologist also will not put a catheter first. And ERCP stenting, as you showed, is the best method of doing it. And the third one, which showed the third case, it is not uncommon. We have not reported this case. The stump cholangitis, we published this case also. About 40 cases were published a long time ago. These stones will prepare for many years without any symptom, and suddenly they become symptomatic. These can have the tip. That's exactly where you apply the tip also. Those stones must have been very small, and it gradually, with inflammation, as you said, it gets eroded into the bile duct. That's one of the causes, actually. Thank you very much. Otherwise, I really enjoyed the session. Thank you.
I request the panelists, the moderator, and the chairpersons to please remain on the stage for the photographic session. Before that, for the audience here, the delegates were gathered. Kindly do not leave. I have a very important announcement to make. This is regarding the prizes which have to be won today regarding the quiz. So kindly remain for a few seconds more. Like in movie, the theme was fully about cinema. So accordingly, even the prize is coming with a surprise element. The first prize is unanimously chosen already, but the second prize is a tiebreaker. Can we cheer for them, please? Can we put our hands together and cheer for the second prize? It's a really great thing. Two minds are, think alike, and they've got the same marking. So now, after this, immediately we are going to have the tiebreaker. The two people who are competing for the second prize will be announced, and you need to be alert because a question is going to be asked. I request Dr. Pata Radhakrishnan to please come on stage. And also, I request all of them to remain on stage. And Dr. P.K. Reddy to honor Dr. Rajkumar with a memento, please. Thank you. And a photograph to be taken over to say. Thank you. Thank you. Now I request Dr. Pata Radhakrishnan to please praise this occasion, and he will be informing who are the two people who are competing for the second prize for Alexa.
Sorry for